All right, it is 12:01. Thank you all for joining us for Nevada Cancer Coalition's Cancer Education Lunch and Learn series. This webinar is expanding access to cervical cancer screening, the role of self-collection. Just a few housekeeping reminders. Please use the question and answer box or the chat function to ask questions. Dr. Kepka has graciously agreed to take questions throughout, so if you have one, put it in there or raise your hand and we will get it answered. This session is being recorded and will be posted to the NCC YouTube channel by the end of the week if you'd like to watch a replay or share out. And you'll receive a survey link at the end of the session and via email to rate this session. We'd love you to complete that to assist us with program evaluation. So without further ado, I'd like to introduce our presenter for today. Dr. Deanna Kepka is a Huntsman Cancer Institute investigator and tenured professor in the College of Nursing at the University of Utah. She is a member of the Cancer Control and Population Sciences Research Group and the past director of Global and International Health in the College of Nursing and the founding director of the 400 plus member 12-state Mountain West HPV Vaccination Coalition. If you're not a part of that, join it. It's fabulous. Dr. Kepka's main research interests are the gaps in healthcare access and quality for vulnerable populations as related to prevention, treatment, and survivorship of cancer, with a focus on HPV-related cancers locally and globally. She has more than 80 peer-reviewed publications in HPV vaccination and cancer prevention, and currently is the principal investigator of the PREVENT, which is an HPV vaccination 5-year R01 funded by the National Cancer Institute. We are so very grateful to have you here today to talk to us about this really important tool for HPV testing. I'll turn it over to you.
Thank you so much, Lily, for that introduction. Welcome, everyone, to a lunchtime seminar. Feel free to ask questions, and I'll answer them to the best of my ability as we go along. I really like taking little breaks, so I am open to all the question asking that you want to do. So I'm here to talk about expanding access to cervical cancer screening, the role of self-collection. So I'm an HPV vaccine researcher and scientist, and I've been involved in HPV vaccine since around 2006 when it was approved for girls. But over the last few years, I've been expanding my research program to also work in the area of HPV self-collection. So we're at the cutting edge of this new opportunity for cervical cancer screening in the United States, and I'm excited to present to you some snapshots of what we're learning and what we're doing and what we hope will be happening right now. This is my team. I'm really appreciative for all of their help in putting these slides together and keeping our studies going. Yes, special thanks to Becca and Kayla for the hard work that they've been doing on our HPV self-collection programs. I have received 2 Merck Investigator Study Program Awards. Merck is the pharmaceutical company responsible for HPV vaccine Gardasil. I'm also an expert consultant for Merck, but none of these disclosures are relevant to my talk that I'm presenting today. So a little bit about Huntsman and the Mountain West region. We're really happy to be here talking to all of you in Nevada, and I'd love to hear where you're from. So please put your location in the chat. It would just helps me get a feel for who's here today. You know, what type of work do you do? Are you in advocacy, education, public health, or clinical practice? Or if you're not in Nevada, what other states are you in? Please share in the chat where you're from, and we can get an idea of, you know, who's here today. Let me see if I can, I don't know if I could see other than the panelists, but maybe they could type a summary of who is present today. So Huntsman is now, we have been for a while, but we are the only designated National Cancer Institute Comprehensive Cancer Center in this 5-state Mountain West region. This is the area we serve. It's about a little bit less than 20% of the US contiguous landmass, 10 million people, 43 American Indian tribes and nations, and more than 35,000 cases of cancer annually. So it's important to us to do outreach and education activities, not just in our home state of Utah, but in our neighboring states, such as what we're doing today with all of you. So last week was International HPV Awareness Day. I just am putting this out there just so you know, and the work that you do, if you could try and share this next year. It's always the 4th of July. I always remind myself that it's March 4th for HPV cancer. So it's March forward for HPV cancer prevention. That's the way, a little trick that I have. And it's sponsored by the International Papillomavirus Society, but really it's taken off worldwide at the state and local levels and in trying to improve knowledge about the HPV virus, which is the most common sexually transmitted infection in the world. For those of us who are not vaccinated, 1 in 4 of us will have it right now. 80% of us will have it over the course of our lives. Most of us clear it within a couple of years. But for those of us who don't clear it, it could advance to precancer or cancer. There are 6 different types of HPV cancer. The most common HPV cancer is oropharyngeal, cancer of the back of the throat. Second most common is cervical in the US. Cervical, however, is the most common HPV cancer worldwide. And then other cancers are anal, penile, vaginal, and vulvar that are caused by HPV. March is also Women's History Month, and I wanted to just give a little shout out to Mary Papanicolaou. Mary Papanicolaou, or Andromache Papanicolaou, was the wife of Georgios Papanicolaou. Georgios Papanicolaou was the first to look at the possibility of treating cervical cancer through screening. So using a screening tool, and that's where the word Papa Nicolau comes from, to look for abnormal tissue in a woman's cervix. So he developed this science, which has been life-saving in the US. I mean, it allowed us from having cervical cancer as one of our top 10 female cancers to not even in the top, 15 presently, and that's because we've had this screening tool since the 50s and 60s being integrated into our primary care. Around the world where we don't see cervical cancer screening being implemented with follow-up treatment opportunities, cervical cancer is incredibly deadly. It's often the number 1 and number 2 most deadly female cancer in most of sub-Saharan Africa and a lot of Latin America, Southeast Asia. But what I'm here to talk about briefly is Mary Papanicolaou's contribution to the development of the Pap test. So Georgios Papanicolaou was not a clinician at the time when he was doing this research. He was, prior to his medical school training, he was doing laboratory tests on cervical cells. And so he needed women to participate in collecting these samples. So Mary herself provided more than 100 of her own vaginal samples, along with a number of her friends to have their cervixes sampled, which allowed her husband to develop the Papa-Nicolau test. And that really has been one of the most life-saving tests for women's cancers in the last 100 years. Cervical cancer is preventable and curable. How is it preventable and curable? It is preventable and curable through cervical cancer screening, which in the past has been done with the Papa-Nicolau test, the PAP test, and also with HPV vaccination. It's curable with treatment for precancerous lesions. So we are at a point in history where the World Health Organization has proposed that we are in a position to eliminate cervical cancer. So I'm at the Huntsman Cancer Institute. I have friends who are oncologists, oncology nurse practitioners. work in oncology settings, radiation settings. And if you told them that the cancer that they focus on or the cancers that they focus on could be eliminated, they would feel the joy that I feel when I'm telling you this story now. It is so exciting that we're at this point in time where we have the tools to eliminate cervical cancer. The gap that we have right now is having the tools, but actually getting the tools implemented in a primary practice and received by patient populations. And that's both boys and girls for HPV vaccine and women and persons with a cervix for cervical cancer screening. The World Health Organization strategy for elimination is getting 90% of girls receiving the first dose of the HPV vaccine before age 15, 70% of women having at least one high performance test by age 35 and another one by 45, and 90% of those with disease receiving treatment. In the US, we want to cast a wider net. We also want to prevent HPV-related cancers in men. So we want our boys and girls vaccinated, and we want screening starting at 21 for persons with a cervix. Our guidelines for vaccination are 2 doses before age 15, 3 doses after. These guidelines could be changing, but we're waiting to hear when the next advisor community immunization practices meeting is going to be happening. It's been postponed with the new administration. But I'm highlighting Alabama here because Alabama is the first state in the United States to say, we have a plan for the elimination of cervical cancer. And I'm really hoping over the next 5 years, other states will come on board with this plan, all of us states in the Mountain West, to really try and get a hold of cancer prevention in terms of cervical cancer. So where are we at in the US? So like I said, we've had the Pap test since the 50s. But yeah, and with the Pap test, cervical cancer is completely preventable as long as persons receive follow-up treatment for abnormal cellular tissue. But that doesn't always happen, right? People slip through the cracks, people don't get the Pap test. People don't follow up on abnormal results. People don't get treatment. There's lots of barriers out there. So even though we have this tool, we have 14,000 cases of cervical cancer each year and about 4,300 deaths each year happening in the United States, and a 67% relative 5-year survival for those diagnosed with cervical cancer. But you could see the death rates are the triangles, the new cases are the squares. You could see how we have had a decline in incidence and death over the last 20 years. And I think a lot of that is, attributable to programs such as CDC's breast and cervical cancer screening program, which allows women access to cervical cancer screening at no cost or low cost. But it has flattened out in the last 5 years. Some of that are pandemic effects. Some of it is just personal level barriers. So in the US, our target rate for 20 healthy people 2030 is 80% of women up to date with cervical cancer screening. Right now, we're at about 75%. So we're 5% off, but that 5% off is real people's lives. And so our most recent data were 74% in the year 2021. I did want to show you though, however, since 2005, the rate of women being due for cervical cancer screening has increased. So we went from about 14% of women due for cervical cancer screening to now 23% overdue for cervical cancer screening. And that was pre-pandemic. So I'm curious as to what these numbers would look like now. So prognosis is worse the longer it goes undetected and untreated. So if you are being diagnosed at a later stage, your prognosis is worse and your likelihood of surviving past 5 years is worse. And we know it's highly preventable, as I've already touched on, with vaccination and screening. but there's room for improvement. I did look up Nevada and I saw that Nevada is at about 76% for women ages 25 to 44 in the year 2022 with being up to date. So that's still, 25% of your women not being up to date. And I bet many of those women who are not up to date are in rural locations where it's much, much more difficult for them to be screened and receive treatment. So the current methods for screening are PAP testing, HPV co-testing with PAP, or just HPV testing. So if your PAP testing is recommended for 21 through 29, HPV testing or HPV co-testing 30 and up. If you receive a primary HPV test at age 30 and it's negative, you don't need another screening for 5 years. And these guidelines have changed over the last 15 years. I'm sure many of you remember when we had the annual PAP test, and then it was every 3 years, and now it's every 5 years. Like, how do these guidelines keep changing? Well, that's largely due to our knowledge of the basic science of HPV, understanding that virus, understanding how it causes cancer, the time delay between infection, precancer, and cancer. Many women who are infected with HPV may not see cancer for 10 to 15 years. It could be quicker for immunocompromised women. So we know PAP testing works, but we know HPV testing is actually better. And that's why if you get primary HPV testing alone or with a PAP, you have a 5-year interval. I do see a lot of challenges in primary care practices offering HPV testing primary alone, HPV DNA testing alone. The US is a little bit behind on getting this integrated into practice. There have been the old guidelines are the ones that I just shared with you. PAP 21 to 29, HPV test, co-test 30 to 65. But there are new guidelines that are being proposed, and that's to allow this, what you look up here, clinician or patient collected high risk HPV primary screening in women 30 to 65. And that's what I'm here to talk to you about today. These are so exciting. These guidelines were just pitched December 2024. When we saw them hit the news, we were like, all right. But now we've hit a little bit of a, I don't know, roadblock and seeing them adopted. And I'm hoping that it happens this year or soon. But as you know, we've had a lot of changes in how these guideline making institutions are operating, how the CDC is operating, NIH is operating in the last few months. So why isn't PAP testing enough? Well, we know the most common factor among women who have a cervical cancer precancer diagnosis or diagnosis are they have never had a pap test or they're overdue for cervical cancer screening. And I focus a lot on women in rural settings, and often there's a lot of wait times for getting in for that cervical cancer screening. They may not feel comfortable if they're in a town of a few hundred people and there's only male providers. It's just a little too intimate. Like, do you want to be getting a pap test from, maybe your ward's bishop? Maybe that doesn't feel so comfortable to be in that vulnerable of a position with your neighbor or someone you know or someone who's part of your church. Travel time for follow-up care, lack of prioritization. I really feel at Utah, we have one of the lowest cervical cancer screening rates in the country. And I feel that with larger families, women put preventative health on the side. Moms put themselves to the wayside. And as a result, these recommended screenings fall behind. Insurance issues, um, uncomfortable past traumatic experiences, sexual trauma. Survivors don't want to be in the stirrups. Maybe having an uncomfortable experience in the past. Um, there's a lot of reasons why women may decide not to get a pap test, may choose to delay a pap test, and furthermore, maybe especially younger women aren't as familiar with these guidelines. And some older women too. I mean, if you have women out in really rural settings, They may not have education campaigns around cervical cancer screening. They may not go to primary care ever for themselves for a wellness visit. So last July was another exciting month when we saw the FDA approved two screening tests for HPV self-collection. Now they were approved for in-clinic self-collection. It's BD and Roche tests that were approved. This has already been happening in many other countries. I was in New Zealand when it was introduced to their practice. It's been happening in Australia for a while, Northern Europe for a while, Canada. So it's not like it's brand new to the world, it's just new to the United States. So we have FDA approval for two options, which is phenomenal. Lots of exciting news out there around this. And the screening is not that complicated. And, maybe some of you are thinking, oh, um, if you have to do it in a clinical practice for this FDA approval, what's the point, right? I mean, you're already there, you might as well get the pap test. Well, if you're in your clinical practice for something else, like maybe an ear infection or strep throat, you could go into the bathroom and do this self-collection, in your own private setting or in the physician's room in your own privacy. We could also use settings like workplace settings where we have uh, workplace health options where they have workplace nurses. They can deliver this option, in a factory, for example, and that's a way to getting it out to large numbers of women within these guidelines. So it still is facilitated as clinician delivered self-collection. They can complete the collection device in an approved setting at their workplace. So this still allows for a lot of expansion, and it does address many of the barriers that women feel in terms of having a pelvic exam. Any questions? I'm going to take like just a couple of sips of water, but if you have any questions, feel free to type in. I can see everyone now.
If you raise your hand, I can turn on the settings to let you answer your question. Or submit it in the Q&A or in the chat.
So I'm now going to transition into talking about the SHIP trial, which is NCI's initiative that started about a year and a half ago. It's been in the planning for many years. I'm the site principal investigator at Huntsman, and my partner is Dr. Katie Maurer, a gyn-onc here at Huntsman. So the SHIP trial is a self-collection for HPV testing to improve cervical cancer prevention. So that's the SHIP trial. It's the last mile initiative. So why is it the last mile? It's the last mile for the elimination of cervical cancer in the United States. And it's really providing screening to those who are under-screened or not screened at all. And the question that I see, I'm going to take a little break because I love taking little breaks, is do you believe that these tests will be available to be completed at home in the near future, similar to FIT and Cologuard? Yes, I do. And the reason why is the second phase of the FIT trial is looking at the effectiveness of offering these tests to women who are, less likely to receive access to cervical cancer screening through a primary care provider. So women who are in rural and remote locations, women who've experienced trauma. So the SHIP trial is going to assess the feasibility of offering self collection at home. We are also offering it in my own pilot program, so I will get to it. So I do think it's going to happen. I just think it might be a little while longer before we see it go into the home option. So the SHIP trial, the last mile initiative, this first phase is looking at the usability and acceptability of the devices and the accuracy of self-collection. So we're going to be comparing patient-collected sample to physician-collected sample. And then the last part is the effectiveness of self-collection underserved and high burden populations. So that is going out and looking at using mixed methods, so qualitative and quantitative, to evaluate women and persons with a cervix experiences of doing self-collect in a home-based setting or in a non-clinical setting. So these are all the SHIP trial sites, and we were really happy to get a site at Huntsman Cancer Institute because as you can see, and I'm sure in Nevada you feel this way also, we're also like the forgotten West often when it comes to big research studies and clinical trials. They tend to hover in, the East Coast and California, and the South is super important too in this area of research because of the high burden of cervical cancer disease in the South. But so we are hosting the SHIP trial here at Huntsman. We're working with 2 primary care clinics that are part of the University of Utah healthcare system, and then also University of Utah Hospital and Huntsman Cancer Hospital. Um, we are including persons who are age 25 and older, have a cervix, and they've been referred for colposcopy. So we're doing the women who choose to participate will do the self-collect simultaneously as when they're doing colposcopy, and then those results will be compared. We're excluding women who are pregnant or have given birth in the last 3 months, and those who've had a history of cervical procedures such as LEEP, cone, laser, cryo, thermal ablation in the last 12 months. We're also excluding women who've had a complete or partial hysterectomy, no medical conditions that preclude them from study participation, and they can't have been a previous participant in SHIP. This is the flow for the primary care practices and the hospital practices. Give the participant education, first are identified, then they complete informed consent. They do their self-collect. They have a questionnaire. Then there's the clinician collected sample, and then the standard of care. And then there's the study assessment where these procedures will happen on the first day of the screening visit and then at future visits also. These are our SHIP study team members. So when you run something like this, it is gigantic. It's, we're just one site of about 30 sites, and each site has 6, 7 people working behind the scenes, and then another, 10 to 20 people working in practice. So it's a really involved study without a lot of funding. So most people are in it because we believe in the cause and we believe in the mission. So again, these are those procedures I was telling you about. It's just a nicer looking flow. Um, and I think we've already done 10 samples and things have gone really well. We've had very few refusals. Women are willing to participate to help move this science along. They receive a small gift card. I think it's like $40 for their time, but most of them are doing it because they want to contribute to the science and contribute to women to having this opportunity in the future. So lastly, I'm going to talk about a self-collection pilot program that I'm doing in Utah at community health centers. This was also funded by the National Cancer Institute, but it was funded as a supplement to our cancer center support grant. So when we look at Utah's federally qualified community health centers, they are significantly lower. This is the blue block for being up to date in cervical cancer screening for women. So this is Healthy People 2030 School, about 80%. And then we see Utahns, falling below 60%. So there's a lot of room for improvement. And we know persons living in rural settings can be 10 to 20% lower. The populations have lower rates of cervical cancer screening. So some drivers for these disparities, I hit on a lot of them earlier, but some of it's cultural views, like, I've only had one sexual partner, so this is just not relevant for me. Maybe there's limited collaborative communication between provider and patient, travel time, maybe systems aren't promptly reminding providers and patients that they're due for cervical cancer screening, provider shortages, clinician constraints, few evidence-based interventions being tested on rural communities. Furthermore, it can be harder for community health centers that work on a shoestring budget, to to do the um, to do the outreach, for example, and to even network with opportunities for like primary HPV screening. It can be challenging to getting all their ducks in a row to make this happen when you're limited in your financial resources and you serve a low income and uninsured population. So these are the instructions that we've adapted. We're happy to share them with you. We want them to be open source and available for anyone. They've been adapted from materials in Australia, but we made ours a little bit more colorful. We have these QR codes for links to surveys for participants to tell us about their experience doing this. And we have a video for them to learn how to do it or for them to learn about the importance of it. And we have been working closely with these clinics, and our clinics their workflow is a little different, where they are asking patients if they'd like to complete this while in clinic, if they're overdue for cervical cancer screening, or they can bring it home and bring it back to the clinic. And they're also doing some phone calling to see if women would like the kit mailed to them. So we're like assessing which mode is most effective. We do know if a person leaves with the swab, the likelihood of getting it back suddenly declines by a lot versus someone doing it right then and there at the point of care. We have made these easy information sheets that can be distributed to patients for whether they're doing the kit in clinic or whether they're mailing it back. And we're happy to share these with you. Um, we have instructions that are specific for if they're receiving the kit by mail and they need to mail the kit back. We also have this video, so let's see how this goes.
I guess I'm pretty happy with how things are going. Oh, hey, where? Sorry I'm late. I just had my pap test. Oh, really? I don't miss taking that test. Aren't you worried about cervical cancer? I'm terrified. Yeah, but thanks to this self-collection kit, I can do it myself. I got a kit
Oh, sorry.
from my clinic. It's an easy way to screen for cervical cancer and just as accurate. First, twist the red cap and pull out the swab. You'll see a red mark close to the soft tip. So I can do it myself. No scraping. No stirrups. Unbelievable. Get in a comfortable position and gently insert the swab up to the red mark. The mark helps you know how far up to go. Does it hurt? Nope. Next, you gently rotate 10 to 30 seconds as you swab your vaginal wall. No need to reach your cervix. It's like putting in a tampon. Right. The kit checks your vaginal cells for an HPV infection. Next, you just remove the swab, place it back in the tube, and write the date. Then mail it to the lab or drop it off at the clinic as soon as possible. If your test comes back normal, you can enjoy peace of mind before your next screening is needed. If the test comes back abnormal, your clinic will call you to schedule a follow-up procedure like a pap test. Quick, easy, painless. And you'll never be late for coffee with your friends again. And to think, most people aren't even aware HPV is the virus that causes almost all cases of cervical cancer. Yep, HPV is a common infection that usually clears up on its own. Most people won't even realize they have it. On the other hand, an HPV infection may cause cell changes in the cervix, which can develop into cancer. But with the self-collection method, cervical cancer is more preventable than ever if HPV is detected early. Exactly. So let's make sure we all get our cervical screening test regularly.
So there is a question about the difference between, so there's the BD on clarity, and then there's the COBAS test, um, about the differences between those. I wish I could give you better, I wish I could tell you the difference between what we're doing, which is with the Copan test versus the other one. But because I haven't done both, I'm not 100% sure, because we worked with University of Washington laboratories because they were the only um, provider of services to support this type of quality improvement study. And so they were able to work with us on using COBAS and the COPAN test. And our clinics get results where they'll know if it's 16 and 18 or another HPV type. But I do think that the BD test gives you information about HPV 31 too. But I would double check what I'm saying. I just have heard this at different scientific meetings. But I'm happy to get back to you, Samantha, with more details when I could talk to people who are using the BD test. But I do think the differences between the two is the results that you get back might be slightly different in terms of HPV type identification. So that's as far as I know. But anyone else who has more information, please feel free to share it. But our participants and clinic partners are able to triage patients, which is what you want to do based on having HPV 16 and 18, that's immediate colposcopy, versus other high-risk HPV types, which is a follow-up with a in-person pap test. So some of the, let me go back a second. So just right now we've had, I think we're a little bit further along than this, but we've distributed about 73 kits and have had about 60, 70 patients complete the test. We've offered like 180, almost 200. So we have about a third of patients agreeing to do this. We've really worked hard to adapt those educational materials. And we're also looking to expand HPV self-collection to unhoused populations. So we have this pilot study happening in 2 rural primary care practices in Utah. So these are, they serve areas of very, very rural and dispersed populations in towns of less than 1,000 people. But then we have another study happening at a large community health center in Salt Lake City that serves the unhoused. And we're seeing for the unhoused population, we're asking them to complete the kits right away, not to take them home. And we're really able to identify, a high level of HPV positive persons that we're hoping to do a great job of getting them back in for colposcopy and follow-up screening. Some other goals of this project, it's not to look at the validity or reliability of the testing, it's to look at how can we help clinics integrate this into their workflow. And so we are working on the 7-step process that we are refining and hope to develop a protocol that can be replicated and adapted for other primary care settings nationwide as HPV self-collection becomes more available. So some final thoughts in terms of timeline, policy, regulatory landscape. I really think this is going to get accepted into U.S. Preventative Services Task Force this year, 2025. I mean, the guidelines were drafted in December, so I'm hoping by the end of the year it will be accepted. And once it's accepted into those guidelines, then it will become integrated into healthcare insurance programs. It's been recently accepted, I know this for Utah, by the CDC breast and cervical cancer screening program. This is huge. So this is happening in the last 7 days. So I'm having a meeting today to look at how we can integrate this into breast and cervical cancer screening programs across the state of Utah, which is so exciting because that allows women who are uninsured and underinsured to have access. Reimbursement has been a learning experience, but we know that if this is billed the same as primary HPV, we don't have any problems. But one loophole we're seeing is that 25 to 30 age range. If we start at age 30, no problems. Those are the tend to be the guidelines that are well accepted across the country. 25 to 30 is ACS guidelines. for primary HPV, but this is billed the same as it would be as if it was a physician collected primary sample, which is super exciting. One limitation that's been huge when I started this work just a year and a half ago, couldn't find a single laboratory in Utah that would analyze these tests, and that's why I'm working with UW. But I found out recently that that's changing, and ARUP will start accepting these tests in Utah, and I'm hoping you have better luck in Nevada, and that'll happen quicker for you. I'm thinking you're a more populated state, so I'm hoping it happens quicker for you. So I'll just briefly touch on some of my other work, which is improving HPV vaccination among the rural and rural Hispanic populations. We've seen an increase in Utah's HPV vaccine rates, moving up from state number 47, really bad, 47 out of 50, to 30. Receiving some funding to do this work, celebrating the 10-year anniversary of our HPV Vaccine Coalition, which covers this whole region out west, including Nevada. Would love to get more participation from you, so please email me if you want to join. We started off as just a 3-state coalition, including Nevada and Idaho, and now have expanded to this whole western section of the US. A lot of success, lots of activity. We sponsor in-person meetings where we offer travel awards. We love to hear from diverse partners all over different communities in the West. My favorite meeting was when we had women working on the Mexico border, doing nurse and primary care clinical practice work around cervical cancer screening and HPV vaccination, all the way up to northern Idaho and Montana at the Canadian border. So we love hearing from everyone in a lot of diverse locations. These are my 2 kids getting the HPV vaccine. Woohoo! My daughter and my son. And thank you so much. That's a wrap. Feel free to ask any question that you would like to ask. I will do my best to answer. Keep in mind, I'm not a clinician, so my experience is as a population scientist and health services researcher. And we're happy to share the videos and the materials with you if anyone would like those.
Dr. Kepka, if you can send them to us, we can send them out to all the attendees as well. Seems like a lot of people really appreciated the video.
Thank you. Yeah, one of the main challenges around moving cell collection forward, I feel, is this laboratories not offering the opportunity for delivering self-collection samples for analysis. So like I said, when I started this a couple of years ago, we didn't have any labs in Utah, and now we may have one. And I only heard about this last week. So I think it's getting the laboratory systems on board with this changing landscape around cervical cancer screening. I do think some providers may feel that if a woman doesn't have a pelvic exam at all, they may be missing something, and that's true. So I think providers need to, for women that are willing to do it, stress the importance of a well woman visit to look for other things, like genital warts or other STIs or other pre-cancer cancer risk. So that is a challenge. When the results come back to the provider, is the brand that was used documented? I don't know if Becca knows the answer to this. She's on here. If she could give a text. I believe it is.
Allow Becca to talk also.
Yeah, I don't know exactly what the results look like for the clinicians. They get a portal that they interact with their lab. Do you know if it says what the brand is?
I know with one of our clinics, they don't use the same brand of HPV co-testing as Copan, so they had to charge it differently, but it was all the same at the end. Like they were able to use, I don't remember the other brand, not Copan. Um, but I'm not sure if it was documented. I know the same like CPT code was used regardless of brand, but I don't know anything else.
We could, if you email us, if you email me, we can ask the 3 providers that we're working with and find out exactly what they see when the results come back. So their results are coming back in a web portal that is set up just for communication of these results for this particular quality improvement project. They don't, so that's the thing. It is, you don't know if it was done by provider or self. And that's why we aren't having challenges with billing insurance, Medicaid or Medicare for HPV self-collection because it's being billed as primary HPV testing and it doesn't specify whether provider or self. And Becca, correct me if I'm wrong.
No, that's correct.
But I think I'm thinking like in Nevada, you've got a lot of rural landscapes. And I'm also thinking, I go to Las Vegas once a year. I'm sure there's a lot of people who aren't up to date in their cervical cancer screening um, that are at risk for HPV. And maybe they have they have stigma or access challenges to getting primary care. I'm not sure what your cervical cancer incidence and mortality is. I'm thinking it's probably higher than Utah, but yeah, that's something that might be worth looking up too.
You're inspiring some thoughts, so yeah.
Yeah, I would think it's higher.
Yeah.
I would think it's higher.
All right, I'll give it another moment for more questions.
And as we get further along with the SHIP trial, I mean, I'm sure there's going to be more dissemination of findings because we're just one cancer center. There's 26 other cancer centers. So I think there's going to be a lot happening. And the SHIP trial is also looking at both testing options, both FDA approved tests, and I'm sure they'll do some comparisons of those tests too.
Where should the audience and ourselves here at NCC pay attention to those results as they're disseminated so we can get the word out more?
I mean, you're welcome to contact me at any point. You're also, I would think your CDC contact would be in the loop also for your cancer consortium, your cancer program. But there's been some limited dissemination happening these days. But I will at least know what is available to anyone in the clinical trial position, right? So, and I do know the head PI, I see him quite frequently at meetings and have a working relationship with him to get the scoop from him too.
Well, thank you so much for sharing all of your current resources and that future dissemination, those dissemination challenges and our usual chains not working as well. It's much appreciated. All right, if there are no more questions, thank you all for your time. Please remember that the survey will be coming in your follow-up email. We'd really appreciate it if you do take that. And we should be posting this soon to our YouTube channel, so send it to a friend as well. And if you're not already on the HPV West group, that's a great place to go to for more information.
Yeah, feel free to email me. And we can add you to attending our Mountain West Coalition meetings are optional, but you'll still get our monthly newsletter. And if you attend one a year, that's great. And just having on our list really helps because we like to know who our potential partners are in the West when we're looking for different opportunities for different studies. For example, the pilot program at the 3 clinics here in Utah, the 3 systems, those relationships came about from the coalition. So when we have working relationships from our coalition and we have an opportunity to do a pilot program like on HPV self-collection, we can reach out. And right now we're looking to expand HPV self-collection to Nevada, Idaho, and Wyoming. And so if you may be interested in getting involved in a much longer pilot study, like a 5-year pilot study, we're going to put in a grant this June. So feel free to email me. We're always looking for partners, and we try and be like a reasonable, group to work with. We offer clinics a clinic impact fee because we know the burden that this takes on clinics when they're implementing something new.
Right. Well, thank you again for your time. And thank you all for attending today. We look forward to getting more information out as this continues to develop.
Thank you for listening.